is the secondary coping which has been integrated with the denture in maxilla. So the primary coping will be cemented permanently to the abutment teeth and remains in the patient mouth all the time. So it is fixed. The secondary coping, it is rigidly attached to the denture framework, comes out along with your denture. So the retention, it majorly because of the frictional fit between the primary and secondary coping. When the patient applies the gentle force, you will be able to retrieve the denture base along with the secondary coping. So the primary coping margins remain supragingival, as I said earlier. Highly polished metal coping with the denture intaglio surface reduced with the plaque accumulation. Over embrasure and smooth emergence profile permitted access for brushing as well as for the interdental aids. So strict oral hygiene instructions and regular recall visits ensured with the long periodontal health of two abutments alone, which is retained in my maxillary arch. So this is an extraoral picture for the outcome. So better retention when compared to our previous FPD, comfortable chewing, reduced prosthesis movement, good hygiene maintenance, no soreness or instability. This is not in pharmacology will be saying no, vomiting, dizziness. It's not like that. This statement was provided by the patient after the prosthesis insertion. So what are the key learnings we need to take up from this case? So it is going to have and ridge resorption will be reduced by retaining even two teeth on that particular alone. Comfort with the minimal preparation, superior splinting and longevity, and preserve the teeth over the extraction. Again, for every case we can't say I'm a superhero. I did the best treatment to any patient and every patient. That is not possible. We should know our own faults and we should know where we can correct with it, and that's how I came up what are the specific limitations in my treatment planning. Compromises the ridge anatomy because long span RPD stability, unilateral support. Everybody can question me. It is just 2728 on the opposing. There is no opposing tooth also. Why do you want to take that teeth and give in primary and secondary coping? That will be the most of the question. Simply my answer is I don't want to extract the teeth. It will extend the life of the teeth. Very simple. The patient will come again 5 years next to you if the process is failure. But I'm not turning my patient even with a single teeth into a completely edentulous situation very immediately at that fraction of moment. That is what I want to advocate. I might differ from the recent current generation people, but I don't know. Somewhere I lie in that category. Patient is diabetic, so surgical implant risk will be there, and non-ideal tooth arrangement as well as the occlusal load distribution. These are the limitations of this case. So what are the factors which made me to choose within telescopic denture? Strong abutment. Though it is going to be 2, it is strong for me. Diabetic status, it has a good splinting effect. It will give some amount of inflexibility at the same time with the frictional locking with the two remaining teeth. Control movement, hygiene access, bone preservation, and despite the unilateral abutment with no opposing teeth, the telescopic provided with an excellent